All right. Welcome, everyone. Good afternoon or good morning, depending on where you are. Welcome to today's Pathways to Resilience Learning Network session. My name is Tanya Schwartz, and I'll be facilitating today. So today's session is on approaches to screening for adversity across different settings and populations in order to promote healing. And for those of you who are joining us for the first time, Pathways to Resilience is a national initiative to raise awareness of the impact adversity and trauma can have on the health and well-being of individuals, of families, and communities, and to promote strategies in states and communities across sectors to prevent and address the negative effects of trauma, to really help our youth and families heal, and to develop strategies for coping with stress. So for just some quick logistics before we jump in, this session is an hour long. We use a question and answer format. We are recording today, and the recording will be posted on our website, along with key takeaways and some resources. So throughout the session, my colleague Leslie Schlichting will be sharing resources and managing the chat. And I just want to thank her for her great work putting today's session together. We also really want to encourage you all to ask questions in the chat, engage in dialogue with each other, share any insights or resources from your own work that are relevant to the session. We are really here to learn from each other. And so there'll be a couple places in particular where I'll invite you to put information in the chat, but really want this to be an open forum for you to be able to contribute and learn from each other. So with that, it's always great to start by knowing who we have on today. So for those of you in the audience, if you can feel free to introduce yourselves in the chat, and that way we can see kind of the range of sectors and organizations that are represented today. All right, with that, let's jump in. So we are really excited to have three amazing leaders joining us today from Virginia to California across all of our time zones. So we have Lori Crawford from Virginia, Makai Owen from California, and Antoinette Medina, who's also coming to us from California. And so we're going to start by turning to them so that they can introduce themselves. And so I'm going to start with Antoinette. So Antoinette, if you can introduce yourself and tell us briefly about your organization and your role, that would be great.
Thank you, Tanya. Mehiha, Nitwanya Antoinette Medina, Gabalana Tonga Nation, that's down in the Long Beach area. I'm the project coordinator for the Tribal Epidemiology Center's Building Public Health Infrastructure, or TechFeed, cooperative agreement with the CDC, or the California Rural Indian Health Board, California Tribal Epidemiology Center. CTEC, the Tribal Epidemiology Center here in California, is one of 12 Indian Health Service techs that assist in collecting, interpreting health information for American Indians and Alaska Natives in California. We receive core funding from IHS. We have supplemental grants along with the tech fee grant that I manage. And our mission here is to work directly with tribes and Indian health programs that monitor the health status of AINs, American Indians, Alaska Natives in California, then develop effective public health services that also respect the cultural values and traditions of our communities here. I feel that's very important because I am California Indian as well, so this is perfect opportunity for me. And in this capacity, it's where this our Tribal Adverse Childhood Experiences project came about, TASIS. That's how it was launched. So thank you all for being here.
Great, thanks, Antoinette. Lori, would you like to introduce yourself next?
Sure. Good afternoon, everyone from everywhere. I'm Lori Crawford, and I am the director of our state's Office of Trauma and Resilience Policy. We are actually housed in our Virginia Department of Social Services. In Virginia, our department covers a huge range of services in addition to the traditional child welfare. We also do all of our benefits programs, as well as a lot of community volunteer services, working with community action agencies. We do child support enforcement. They're all housed in the same agency in Virginia, so we're rather large. but specifically our office is charged with kind of three layers of audiences or work. The first being our internal culture change for social services, specifically at the state and local level. So trying to be more trauma informed and healing centered in the work that we do. And so in that role, we provide we're a support function to our other divisions at the state agency and at the local level. We also coordinate a lot of the cross-agency work. So trying to better coordinate our state's trauma-informed leadership team, which is made up of representatives from most all of our child, youth, and family serving agencies in the state. So about 13 of those, and try to coordinate that work. And then most closely linked to this particular training event, we also manage what's called Virginia Heals, which is helping everyone access linked systems. This is like a branded name, but essentially this is all of our work with service providers at the local level from all systems. So we have developed a trauma-informed model of service delivery, of which the screening tool we'll be talking about today is part of. So it's a whole toolkit of resources and really specific to providers and agencies working in community across systems. So from child welfare, juvenile justice, education, behavioral health, et cetera, that they're all working off this same page and using the same tools. And so through that, we do quite a bit of technical assistance in helping folks to implement that.
Great. Thank you, Lori. Excited to dig in on all those things today. And last but not least, Makai Owen, would you like to introduce yourself?
Sure. Good morning, everyone. Excited to be here. My name is Makai Owen. I'm a pediatrician based in Sacramento, California. As a pediatrician, I practice in a youth detention facility, and I'm also the co-principal investigator for the UCLA UCSF ACEs Aware Family Resilience Network, also known as UCAN. And UCAN implements California's ACEs Aware initiative, which is the first in the nation effort to screen patients for adverse childhood experiences to prevent and mitigate the impact of toxic stress. Thanks.
Great, thank you all. So we're excited to have so many different sectors represented here, different populations that you all work with, because we really wanted to be able to bring this all together to learn from these different perspectives. So let's start by talking about the why. Why do you screen for adversity and how you're generally approaching screening? So Makai, I'm going to have you go first. So it'd be great if you could talk about, again, why you screen, including what is the goal of screening under ACEs Aware, the setting in which you screen, who you screen. Can you give us a sense of what that looks like?
Sure. And I think I'm gonna ramble for a bit, so you can jump in if I go too long. But before talking about kind of ACEs Aware, I'll kind of talk about how I started screening and what that looked like for me. And so I remember being a pediatric resident and reading and learning about adverse childhood experiences and toxic stress. And that was, I think, before most people screened, before ACEs Aware, and before there was a lot of, I think, resources out there for screening. And so I did a fellowship in Florida called Community and Societal Pediatrics. And through that fellowship, had the opportunity to care for and collaborate with a lot of young people who were in challenging circumstances. And so for me, I had a clinic that was mostly composed of youth who were involved with the legal system or youth in the child welfare system, or youth who had significant behavioral issues with frequent suspensions from school and expulsions. And so in taking care of the young people and their families over time, really came to learn that a lot of the young people that I was caring for just had a lot of anger, a lot of anxiety, I guess short-tempered. And the conversations with them, I think that they couldn't, most of them really didn't understand or think much about why they felt that way or what was the root cause of that. And all of them, of course, wanted to get better, wanted to do better, navigate, their environment and their surroundings better. And so having learned a lot in residency and in fellowship about the impact of ACEs and toxic stress, kind of having an idea or having the knowledge that a lot of the behavioral issues that they were having were related or grounded in both ACEs and other forms of trauma and adversity. So when I first started using the ACE screening tool, I just used the 10 questions from the Kaiser study. And it was really just to have a conversation with patients and with family. So, back in that time, I used to give the tool to both the patient, but also the caregiver who was with them, and just use it as a bridge and as a way to open the door in a non-threatening way to have a conversation with them about how childhood adversity in the absence of protective factors, or how that imbalance between adversity and protective factors can really affect a young person's behavior. And at that time, it was really about their behavior for me, because I was still, I think, learning how to communicate. And I think as I learned more, got better at it, and that evolved into using it as a bridge to talk about their behavior, but also to help them understand that the associations between adversity and changes in brain architecture, in the neuroendocrine metabolic immune systems, and how some of these behaviors and feelings were really rooted in the physiology. And I can say that time it was, I still do that to a large degree, and it's been great for me to be able to use that as an opportunity to discuss with patients and families. And I think in those conversations with young people, they've got, for the most part, I think, a lot of relief and understanding in learning that, hey, maybe this isn't my fault. Maybe I don't deserve to be kind of in some of the challenging circumstances that I have now. And I found for me, it really kind of, at that point in my career, really opened the conversation to the content, opened the conversation and opened the door to a better healing context and healing relationship between my patients and my families, and the families that I was caring for. And so now I think, as learn more and working with ACEs Aware, becoming more structured in screening and responding and what that looks like. And so now in the context of screening, mostly in primary care, screening as a way, at least for me personally, and I think with ACEs Aware, as a way to identify risk of toxic stress. So again, I think we'll talk about it a little bit more throughout the course of today's conversation. But now in the clinical setting, when we're screening for risk of toxic stress, and not necessarily for specific exposure to specific ACEs. So I can pause there.
Thanks, Micah. It's really helpful background, and great to hear how you got into this in the first place. I'll turn it to Lori now. Lori, can you talk a little bit about why you think screening is important in the social service and juvenile justice sectors, and what you all in the state of Virginia are doing in this space?
Yes. So our screening tool that we developed as part of a grant project, which I think I'll be talking about in a little bit, is specific to children, youth, and transitioning young adults, like up to the age of 21. 3 different versions, of course, for the different ages. But essentially, the root of our creation of our tool, it came from a grant. But essentially, the point of using it was to have a tool that could be used across systems by different people and different providers and different systems to direct and make really individualized child and family centered services and referrals to hopefully community-based services. That was really the overarching thing. So we found that there were, for instance, there were screening tools for exposure to domestic violence, and there were screening tools for bullying, and there were screening tools for, child sexual abuse, and there were all these different ones, but typically they were for one specific thing, and they were specific to one particular system, and use the language of that system. We also found that most of the time people were using the term screening and assessment interchangeably, which I think is an important distinction to make, because the purpose of our screening tool is not to make a diagnosis whatsoever. It is really to direct services or the need for further assessment. And the reason that we think it's so important to kind of know more about the experiences of the child or youth is because, for example, we have several questions that may indicate trafficking. So that would indicate the need for further assessment, which should be done by a clinician, which is much longer process. But it's important to know that, versus if you have someone who's maybe experienced exposure to family violence or whatever that the case may be, there may be different referrals. You might refer to your local domestic violence program to their services specific to that. So it really was for us to be able to have a way of communicating in a tool that you receive the training, a brief training, a couple of brief trainings that anyone who received the training could administer in about 10 or 15 minutes to just give you more information that would help you direct referrals instead of kind of using those go-to, like you think something is going on and you send a kid to the community services board, crisis services. And that's kind of what was happening. So what we're trying to do is really just to make things more individualized to children, youth, and families in the state. And I will dovetail off of Micah's statement because we are implementing it in statewide in our juvenile justice system specifically. And a lot of those reasons are the same because we found out that, that goes back to that whole question of finding out, what happened to you instead of what's wrong with you. And we know that our juvenile justice engaged kids have experienced really high levels of trauma. And so it's not surprising that they are engaged in the system. And we really want to keep them as best we can to prevent further involvement with systems, in general. So if we can find out what's going on early, then hopefully we can prevent some things that might go on later in life.
Absolutely. Thanks, Lori. So Antoinette, we know that you've supported the development of a new screening tool that I know you're going to talk about in a little bit. But can you talk about the importance of screening for adversity within Native communities and tell us a little bit about the settings in which your tool is going to be implemented and the population with which it'll be used?
Of course. We found that the AIN populations, and if you hear me say AIN, it's American Indian Alaska Native. So you'll hear me refer to that throughout our discussion today. But AIN populations, they're more likely to experience ACEs, putting them at greater risk for smoking, alcohol abuse, etc., drug abuse, depression, suicide, you name it. Everyone here knows this. But we also know that the tools to assess ACEs should help providers intervene earlier to prevent these harmful outcomes. But assessing ACEs in tribal communities is very difficult. They have limited resources or limited validated tools that don't account for cultural context, including the intergenerational impact of historical trauma, which stems from colonialism, displacement from our ancestral lands, forced cultural assimilation, etc. They also don't account for protective factors that mediate associated health outcomes, and this results in incomplete representations of trauma and health amongst entire AIN communities. So when screening tools are developed using a Western framework, they largely focus on deficits, use, neglect, household challenges. So there's a lack of community input or testing. Again, they're deficit focused, don't speak to the protective factors that promote resiliency. They be not delivered in a culturally appropriate way. They lack the pertinent constructs of trauma experienced by Indigenous people. And in our communities, we demonstrate resilience through culture, through our language, through ceremony and tradition. These are important values to us. So knowing all this, in partnership with Allison Kelly and Associates, we developed the Tribal Adverse Childhood Experiences Screening Tool, or TACES. You'll hear me refer to that throughout this discussion as well, in response to the need for screening tools that adequately reflect the Indigenous experience. We created this for implementation in California tribal communities. However, we want to share this with the Indigenous community nationwide. And I'll finish this with the quote. One of our site leads for community outreach on our project here stated, "There's no way to recover unless we uncover." And that was from Darnell Aparicio. He's a Manchester Point Arena Band of Polo Indians. And we just found this quote just said it all. It was so profound for us. You feel it sums up the need for screening for adversity with tools that adequately assess the resilience and trauma in our specific communities.
Thank you, Antoinette. So now let's talk about, as we prepared for this session, you all wanted to talk about, okay, well, what do we have to do to prepare for screening? What needs to be in place in terms of our organization, our community, right? How do we think about what needs to happen before we can even start screening? So would love to ask you all, starting with Lori, then Antoinette and Makai, based on your experience, what needs to be in place at an organization, externally within the community, to really effectively prepare for screening for adversity? So Lori, do you want to jump in first?
Sure. So I think, first of all, I think there needs to be some training, not on the specific tool necessarily. Well, you need that too, but first there should be training on trauma-informed screening. Like, what does that look like? Why is it important to get that buy-in? And also really to address concerns or discomfort that folks may have with screening, dispel some myths about screening being re-traumatizing by asking the question, to really engage in those open conversations. So really that training piece is super important. I also think that there need to really, particularly at an organization or systemic level, there needs to be clear policy and practice guidance on when it's going to happen, who's going to do it, and then how often rescreening should occur. So for, with a system as big as our juvenile justice system in Virginia, this took a number of years because it was very much, we wanted to have people who were going to be in the field doing it, their policy folks, people, and there were all these questions. We wanted to basically have it up front so folks would know what that was going to look like in their system. Do you do it upon intake? Do you do it within the first 30 days? Do you want to have 60 days? What kind of relationship do you want to have established? People are talking about rescreening, particularly if there's like if you think about the child or youth is in a new living circumstance, that might be a reason for rescreening before an annual basis or whatever it is that you decide. But I think that where it's going to be is probably the biggest challenge, like the where, who, what, where, when, and why, piece. And kind of along with that, my experience has definitely taught me that it is super important to have the buy-in, to be transparent and have the buy-in of the people who are actually going to be administering the screening tool before you implement it, because we have learned that many times it sounds like a great idea, it sounds progressive, and people want to be leaders. And so a lot of times leadership may sign on to something, and then you get there's the people who are going to be doing it to provide the training, and they're not so bought into it. So that's another kind of big lesson learned. And then finally, to prepare, we always recommend that there be a knowledge of your resources that are in community. And again, going beyond those go-tos like your, community services boards or whatever that may be. But we actually, and I'll put the link into our toolkit for Virginia Heals in just a minute, but we actually, when we started piloting the screening tool, we developed a process called community resource mapping, and actually like a playbook for what that looks like. Because what we found was we could carve out about 3 hours of time and have folks from different systems in the field and have them go through a process where they go beyond their go-to referrals and get to the point of what are some resources in the community that we don't even necessarily think of as services, but they really kind of help support and build resilience and protective factors. And folks really need to know who those people are, who those agencies are, who those groups are in community before they get going, because that's always the question is like, well, what if they say yes? Then what do I do? And, you know, we make the statement to them, well, you know, these things still happen to them, whether you asked about it or not. They still need these services. But I think it just adds that confidence when they have that additional knowledge of what those resources are. So I think essentially those three things, the policy and procedures and the training, and then a knowledge of the resources are the key for me.
That's great, Lori. Thanks. Antoinette, would you like to add to that?
Yeah, thanks, Lori. I know I'll probably repeat some of the things you said, because we found that as well. Looking at some of the lessons learned from our TASTE project, we decided to come up with an implementation guide for organizations that gave some advice if you're looking to implement screening tools. And first, we talk about identifying your approach, defining your process, see if your screening tool will be, or how it will be implemented. Will it be implemented countywide or community-wide, or with a targeted population? Some of our sites did like behavioral health patients specifically. So that really needs to be identified, and you need to define your data collection process and methods. Pre-identify your partners or programs that can provide information, resources, services to support those community members. And importantly, identify how the data will be shared after, if it's going to be shared after. For Indian communities, it's a very important piece to this project and to any tools or any data that's collected. And then to obtain leadership support, that's key. Get buy-in, be sure that the tools and the processes are shared with your leadership team. We found that it was successful when we brought leadership in, talked to them with this project staff. That we described the importance of why you want to screen for TASEs. Not everyone understands TASEs in trauma-informed care, so that at that point it's a teaching tool. And obtain and incorporate their input in the process. And when it comes to the screening tools, it's important that the communities are helping to develop them. We did an extensive feedback time for our communities to share about the tool when we shared it with them. It went through our Tribal Epidemiology Center Advisory Council, which are made up of community members and leaders in the Native network here, and we really need them to inform our work. And communities should feel free to create or modify their tools based on their particular values or their particular culture at the site. And it's also key to ensure that the providers who implement the screenings left in a good way after. Too often, individuals are given screenings and then they're just left to mull over those, could be triggering questions. And our communities can see this as mistrust, and that entirely defeats the goal of healing our people and our communities.
Thanks, Antoinette. And so I'm going to turn to Makai in terms of what you think needs to be in place at an organization or externally, but also would love for you to address, and both Lori and Antoinette have talked about it. We've had a couple comments in the chat about, how do we ensure we're not unintentionally shaming people or re-traumatizing people. So Makai, would also love your thoughts on that as well.
Sure, and I think it's kind of related to the question that I saw for me in the chat is, what do you advise or offer to assure the tool is not unintentionally shaming or providing more stress or trauma, especially when services are not adequately addressing the sources of trauma? So I speak behalf of myself as a Black pediatrician that practiced in a Black community where there wasn't a lot of resources in place, and there was a lot of trauma, and my personal experience, it more so than like a structural racism aware. But I think we started this question about what needs to be in place organizationally or externally. And I totally agree that it's really important to have those things in place. But I started the first time I screened a patient for ACEs, I went online and printed out the questionnaire and gave it to them and had a conversation. Like there was no organizational structure in place to have it. And it was after that first one, I continued to do it because it was a transformative way for me to have the conversation with that patient. And I'll say that to say that I intentionally chose to want to work with youth who were involved with the legal system and to have a clinic that, you know, purposely had a lot of kids that were involved with the legal system, welfare system, suspensions, expulsions, behavioral issues, because that was an advocacy passion of mine and wanted to be a part of working with kids and families in my community to do that. And so I think in doing that work, and I'm sure for many people in this call, you know, we already know that the trauma exists, whether or not we're screening for it. And then two, the youth and young adults especially are impacted by it, whether or not we ask about it. So I totally think that a screening tool can be given in a way that is harmful or traumatizes a patient. But in my personal experience, and I think this is part of just because of how I try to communicate with my patients, it hasn't necessarily happened for me, right? I haven't been in a situation necessarily where a young person had experienced many adversities. And I think more importantly, that young person was impacted negatively by toxic stress or the impact of those adversities. And then I gave the screening tool and it was just like an aha moment for them in a negative way. I think for me, it's been an aha moment for them in a positive way. And so I say that to say that in addition to the things that we've talked about externally, I think that clinicians, providers, other people who are administering the screening tool have to look internally and think about their ability to communicate with patients and clients and their ability to have challenging or difficult conversations about adversities or social circumstances or other issues that may negatively impact patients' health. And I would say from my experience that the more that I committed to understanding that these issues were negatively impacting my patients and their families, and the more I committed to understanding that I needed to discuss this with them and communicate with them about it, I think the better that I got in terms of having that conversation with them. And so, like I said, when I first used the screening tool, there was no organizational support, but what I found was it was a really powerful way to open the door to have a talk about adversity in childhood without patients and families being concerned that I was asking specific questions that might get them involved with child welfare or that I was being punitive. You know, I'm going to give you this questionnaire that asks these questions. The reason why I'm giving you this questionnaire is that a lot of medical evidence suggests. So if you can fill it out, can we talk about it? And after talking about it, I can say, oh, you've had a lot of these experiences. You know, I bet there's some experiences that you've had that aren't on this list. Are there anything that stands out that you want to talk about? Oh, well, you've been through, you know, oftentimes with young people, I would say you've been through a lot of things that a person your age should not have had to been through. And I bet that's been really hard. This is what I know as a doctor. What do you think about this? And so I think over time, learning how to use that tool to have a conversation that promotes healing. And so I think a couple other things that come up a lot that are a little bit in the chat and a little bit in the conversations that we're talking about is, you know, I agree that it's extremely important that we have the resources available to support the patients, and ACE is aware. I think we've invested in working in a lot in that. But at the same time, just my personal experiences, I know that I have had healing conversations with patients through a conversation about cumulative adversity in the absence of having all the resources I have in place. And that's not to say that every patient had a transformative outcome or even that every patient had a positive outcome, because they didn't. But I know that in that clinical encounter, that they left having a better understanding of kind of how they got here, and at least some strategies about what we can do or what they can do to help heal. And at that time, you know, when I was a novice, the strategies, you know, I wasn't as knowledgeable about them then, but I think that's the other part of this conversation that's really important to lift up, that especially for me as a pediatrician, as a clinician, you know, for ACEs Aware, we have the stress busters, which are evidence-based strategies to mitigate the toxic stress response. So, you know, may have patients who I would think would benefit from mindfulness or eating better or sleeping better, or access to nature. But sometimes it's hard to have that conversation if you haven't made that connection, right? So I think understanding that there's strategies to try to mitigate the stress response, and this conversation can help to increase acceptance from patients and families about, oh, there's actually a medical reason why mindfulness might work. For me, has been really impactful to be able to make that connection. And then organizationally, I agree with like everything that everyone said, but I think that, you know, with ACE screening, you know, if you just pull out a screening tool, give it to a patient and run through it through a checklist as like a checklist only, I think whether it's organizationally or whether it's individually, it's not likely to have the positive impact that many of us believe that it can have, and it can be harmful. So I think there's a lot of work that organizations can do to understand, you know, in the context of your organization, why are you doing this? You know, and that looks different. You know, I'm a pediatrician, but I do other juvenile justice and mitigation work. Why your screening may look different in different contexts. And that's a conversation that I think an organization needs to have. And then two, there's a cultural competence conversation oftentimes, because people who are using these screening tools or asking these questions need to have the skills and the ability to have these conversations in a way that is non-threatening, and explain to patients and families or clients why you're asking these questions, and why you're asking questions in a way that doesn't alienate them or make them likely just to go zero down the board, because, you know, they don't have a trust. And going on a little bit too long now, but I'll say there's questions about, I think, structural racism and other issues. And I think it's really important to highlight, at least for me, in my somewhat biased opinion, that oftentimes the concerns that we bring to ACE screenings are really concerns about the structural issues in our organizations, right? As a pediatrician, I can say the lack of trust between patients, families, and the healthcare system that I have experienced in my career is not because of ACE screening. It's because there's lots of reasons to not trust the medical system historically in some of these communities, right? And so I think when we're thinking about ACE screening, or just thinking about how to investigate the impact of cumulative adversity in patients or clients, it's really important for us to think about how much of our concerns are really rooted in the tool, the process, or the questions, and how much of them are rooted in bigger systemic, historical, and ongoing factors such as organizational, structural, interpersonal racism. And I think as we do the work to identify the best practices and best ways to screen, it's equally or more important to do the work to think about how do we address those structural issues that make it harder for us to screen. If we had healthcare systems or institutions that patients and families trusted and always believed had their best interest in mind, and didn't have a reason, I think, to have a lack of trust or doubt, then screening would look totally different. But we don't have that. So I think it's important to do that work in addition to thinking about ACE screening and response.
Thank you, Makai. Very, very well said. So I just want to pause for a second. I'm loving the questions that are coming through the chat. I do want to invite the audience to put in the chat, are you screening? If you are, what screening tool are you using, and what sector? We would love to hear, you know, what you're focused on. I've already seen some connections being made. So please feel free to jump in the chat and let us know if you are screening, what tool you're using, and the sector. We've talked a little bit about tools already. And I know there have been a couple questions about tools for adults. And so I think maybe Makai in a minute can touch on that too. But just starting with Antoinette, can you tell us about your TACE tool, kind of how it was developed, the current status of it? What would you like to share with folks about that?
Sure, gladly. So working with our health board at the California Rural Indian Health Board, we hear community members, providers, clinicians, they constantly are calling for screening and assessment tools that reflect our Indigenous experiences and values. So in response to that need, we used our grant funds from the CDC to develop the taste tool in 2019. And that was with extensive community engagement. Our tool, we feel, documents the Indigenous trauma experiences and existing resilience and strength-based measures that can better inform prevention, intervention, treatment strategies for our communities. We included more constructs to the taste tool. So our tool has demographics, the original 10 ACE questions, and we did an expanded ACEs with community level indicators. We added cultural connectedness questions and resiliency questions, since we wanted to emphasize resilience. We know that resilience can diminish the likelihood of a toxic stress response, and therefore the likelihood of negative health outcomes associated with ACEs. We felt that this was key to include this important measure for the AIN community. We piloted this project in 3 California tribal health programs, or THPs, from 2020 to 2022. And in 2020, the California Department of Healthcare Services, California Health and Human Services Agency policy staff approved our tool to screen Medi-Cal beneficiaries for ACEs, which was very important for our community. And then between 2021 and 2022, we asked our partners to participate in an in-depth evaluation of the project and the tool that would support the validation portion of this project. And some of the products resulting from this project overall, we have the taste tool, we have community and provider intervention strategies, resource guides. We have an implementation guide that I spoke about before, and an evaluation report and a validation summary and scientific report. So while anyone can create a survey, we know that some surveys aren't valid because they don't measure what we want them to measure. And some of the surveys are not reliable because they don't produce consistent results. So this is why we wanted to validate our taste tools. So going back to the ACE survey, we feel that's a good example. While the ACE tool has been used to document impacts of trauma on the United States population, it's not culturally informed, it's not balanced by strengths, and it hasn't been validated with California tribal communities. So we wanted to validate our tool. And again, with Dr. Allison Kelly Allison Kelly and Associates, we accomplished this. And some of the highlights of that validation project, we had the first ever tribally specific validated tool that measures ACEs while also balancing those constructs of resilience, community, and cultural connectedness. It encourages a culturally informed response to addressing trauma, promoting resilience. And we found that it better equips providers, programs, and communities to develop and implement prevention and intervention strategies that specifically address ACEs, building on community strengths that are already there. And while this tool was created for in our California tribal communities, we want to share that with Indigenous communities nationwide. And we also wanted to model how a community can modify a Western tool and adapt it to be culturally specific to their communities and their values.
Thanks, Antoinette. Lori, do you want to tell us about the tool that you all have been using?
Sure. So we, as I mentioned earlier, were initially, we had a grant for over 6 years from the Office for Victims of Crime underneath Department of Justice, and it was called Linking Systems of Care was the name of the grant. So Virginia and 3 other states were charged with conducting some various activities but it was a demonstration project. So, but the one thing they said that we needed to do was create a screening tool that could be used across systems to assess for a different a wide variety, though definitely not all forms of trauma, but primarily related to victimization, essentially for this particular tool. So we convened a work group that met for quite a while. We reviewed over 50 screening and assessment tools, and developed what is now the screening for experiences and strengths, or C's. And essentially the tool has had different iterations over the years. We piloted it for about maybe over 4 years across, I think it was 5 different communities covering all of the regions in the state, all of our 5 DSS regions in the state, and across various systems. So we piloted it in court services unit, in juvenile services. We piloted it in domestic violence program, and social services, et cetera, et cetera. And for a long time, people thought like it was a screening tool project because it took so much work to pilot it. And we partnered with the Virginia Commonwealth University to evaluate it during that whole time period. And essentially, so our tool is kind of 3 primary components. It is the identification piece, which is, have you ever seen or heard, that exposure piece, with 4 questions. And then it's a question about like direct things that have happened to you ever, And then if they say yes to anything in that section, they go to the reaction section, which are really that symptomology. And it's really to talk about how what they just told you is impacting their daily life, how they're coping. And also has some questions about threat of harm to self or others. And then even if they said no to everything in the first part and you skipped over that reaction section, then you would go to our protective factor section, which is essentially questions about where they find sources of support. So whether it is they find support from their parents or caregivers, or whether it's their friends or their friends' parents, or, a church, mosque, or temple. So we asked those questions about level of support, which we were really glad. As Antoinette said, we heard from a lot of people. We were like, we need to ask about the good things these kids have going on for them and build off of them. So when you have that conversation at the end, it's not just asking these questions. You have that conversation and you use that information that you got from that section of the tool, as well as we don't have, even though you can add up like a score if you wanted to from the first page, it's really all based on the totality of the information, because we all know, and we talk about this in our training, they may have 5 yeses, but then you may look at how they're reacting and they're doing okay because either it happened some time ago, they're already getting services or referrals. People react differently to the same traumas, which is something we cover in training. So those are kind of the primary sections. And, most extensively, because we did the system-wide implementation last year in juvenile justice last July, we actually have a full year of data. And last year, over 2,200 youth were screened using the tool. It was included as a part of every social history. So every time a kid had a social history done, for a pre or post disposition in front of a court, it would be included as part of that social history, not the social history, but as part of it. And we found that the most commonly reported trauma was around community violence. So community violence was like over 70%, followed by threat, 47%, and weapon exposure at 37%. I imagine for a lot of those, all 3 of those were probably yes, because they were linked. Interestingly, 27% of these youth expressed that they had thoughts of harm to self or others. And we have some limited data from some social services, child welfare agencies that have programs within them that have done it. But this is pretty consistent, has been consistent at about 25% or more, which is one of the biggest benefits that we feel like to the tool, is that like they're hearing about this because they weren't even asking before. They weren't asking those questions. And so that's, been pretty telling. Right now, we made a plan to do this, and we're actually doing it, is that I'm working with our juvenile justice folks to, number one, figure out how we can get more, now that we know that this community violence is showing up as such a big thing. Do we have adequate referrals and resources for support? And how do we get more detailed information about the referrals that are made? We have a section on the tool, but they don't always fill it out. And secondly, and more importantly, we are going to look for ways of implementing it earlier in their involvement with juvenile justice, which was our goal overall in the first place. But we wanted to, hopefully when a kid comes into intake, then we can, find out about these things and provide some services or referrals before they get to the point at which they're going before a judge. That would be the hope. But so we're learning a lot. And we did a whole communication rollout with our judges and, guardian ad litems and all of that. It was very well planned out, but that's kind of where we are. And we are trying to now that just spread it out to more systems and folks throughout the state.
That's great, Lori. So we only have 8 minutes left, and we said at the beginning we could probably spend a whole nother hour on this because we have so much to talk about. So trying to figure out how we should finish up since there's so much to say. So Micaiah, I just wondered if you want to just quickly jump in, because there have been some questions about screening adults. Just want to see if you want to weigh in on that, and then if there's anything else you want to share about kind of what happens after screening. But just if you could just maybe say quickly what your tool is and your adult piece that you're focused on.
Sure. So, and there's another question. So first, just from a screening tool, we don't have a lot of time, so I'll just drop in the chat our screening tools because they're there. And I can talk about response and the point in a second, Tanya, but I think there was a question in here about kind of how do you encourage juvenile youth legal system to take an ACEs assessment. And I think that's really an important point, because it goes to, like, I think the first question is, why are you screening? Why are you wanting to do the screen? And I could think for myself, even like working in the youth legal system, there's like several different capacities in which I have used a screen or wanted to use a screen, right? So as a pediatrician in a facility or in an outpatient setting, screening a youth, I might do it as a risk of toxic stress. And just to have a conversation, open the door, make the connection. But I've also worked with, for example, public defenders in Florida to say, hey, use this screening tool as a way to have a conversation with kids about kind of what their life experience has been like, because those life experiences are going to impact how they communicate with you and their level of trust with you and how they might respond to certain questions. And here are some best practices in communicating to people like that. For judges, we've done trainings on how to think about the impact of trauma on brain development and how to take that into consideration when you're thinking about disposition and support for youth. It's also used in a variety of like risk assessment tools, right? So I think that even within the youth legal system, there's probably several different ways of using a screening tool, and kind of the why behind why you're screening, I think greatly influences the what's next, right? So as a pediatrician in the clinical setting, if I'm screening for risk of toxic stress and I have a positive screen, then I might talk about evidence-based strategies to mitigate the toxic stress response, formulate a joint treatment plan, refer to other specialties as necessary, and make connections to community resources or services. If I'm screening as part of mitigation, it might be an education, right? So everybody that's dealing with this youth understands what the science says about how this has impacted them and what is their best pathway to healing. And there's a lot of other, screening, I think is and can be really complex and present a lot of challenges, but also prevents a lot of opportunities to better support, I think, patients, families, and adults. And I think just screening for adults, again, there's lots of different reasons why a person might want to do that. And it depends on your setting and what you want to do. So, and why you're doing it. So I think from an ACEs aware perspective, right, we would recommend screening adults for ACEs because we know that ACEs and toxic stress can have an impact across the life course. And experiences in childhood in the absence of protective factors can lead to toxic stress that can be negatively impacting the health and well-being of an adult. And there's evidence-based strategies to try to mitigate that toxic stress response. And it's also, again, very often for me, if done correctly or not even correctly, but done in a culturally competent and supportive way, I think it really opens the door to have a healing conversation with patients that I think for them, at least in my personal clinical experience, is very often beneficial, I think, to both the health and the well-being of the patient and families, but also for our patient-provider relationship. It's been super helpful for me. So
Makai, I'm going to ask you one more question, and then I'm going to go to everybody for our final action items. So Makai, if people are not going to screen, perhaps they don't have the internal and external pieces in place, what would you recommend that they consider doing?
So it's hard to answer that question without knowing each person's like individual context and reasoning for not doing it, right? And so the first thing I would say is really understanding your reasoning for why you're not going to do it. That could be a logistical issue. You don't have the time. It could be a belief issue. You don't believe. It could be you don't think that the tool is culturally competent. There's a lot of different reasons. But I would say it's important to try to keep an open mind and make sure that we're not carrying biases and propagating biases in our decision-making process, right? And so, I think that for many of us, myself included, when I first started this work, there may be a bias that screening or asking about these questions is so traumatizing that we shouldn't do it if we don't have everything lined up perfectly to support them, right? I'll say in my clinical experience, I have not found that to be true. And again, I think that's partly because I think I've done the work to try to learn how to communicate with patients and families about this. But I think that's an example of how we may be accidentally propagating the bias that people carry around ACEs, trauma, and toxic stress in general. And so I think thinking about why you're not doing it, and two, if you agree with this general statement that, traumatic experiences in childhood negatively impact the health and well-being of individuals across the life course, then if you're not going to screen for trauma per se, I think how are you going to respond to that, statement of fact, I would say? How are you going to prevent trauma? How are you going to investigate exposure to trauma? And how are you going to respond to trauma when you find it? And you or your organization may think screening is not the best way to do so. But for me, if we think ACEs and childhood trauma is a public health crisis, then it means it warrants a response, and it means it warrants an urgent response. And for some people, that may not be screening, but I think the question is, if you believe this is true and screening is not right for you or your organization, then how are you going to go about preventing, identifying, and responding to ACEs and other forms of childhood adversity?
Thank you, Makai. All right, so in our last minute and a half, I'm going to ask Antoinette, then Lori, then Makai. We always like to end with kind of 2 action items for what you would recommend to folks on the call that are interested in screening. And it seems like from the chat, we have very few on here that might be screening currently. So really quickly, if you could share kind of 2 things, recommendations, things you think people need to have in place to jump into the screening world, what would those be? Antoinette, you want to go first?
Thanks. Makai has said it all. And so I'll just refer back to him. You start with the big question of, is your organization ready to implement and commit to new processes? We saw that it was a really big struggle for our tribal health programs. And then also look at the screening tools, and while they can open that door to discuss trauma, communities, individuals, again, repeating what everybody said, they might not be ready for the discussion or the treatment modalities. So you have to look at what screening tools you're going to implement, and I'll leave it there.
Thanks. Lori, any final thoughts?
Yes, my 2 would be just to really kind of try to get a multidisciplinary work group and make sure you have people from leadership to frontline workers, and depending on where and how you're going to screen, to people in hindsight, people with lived experience may be good to include on that group as well, to look at the tools and decide if it's right. And the second is not so much kind of a tip, but I guess just reminding again of the things that Makai was saying, is that really be prepared to explain the why and be prepared to share with folks that we're never going to have as many resources as we ever think that we need. We're not ever going to be there, but that honestly, just asking the questions and having the discussion is so validating and takes away so much shame, that in itself is pretty valuable. So that's it.
Thanks, Lori. Makai?
Yeah, I'll try to go fast. So I think first, for me, like, I genuinely believe that ACEs and trauma and cumulative adversity, toxic stress are public health crises, right? And so I think if you believe that, then it requires ethically or more like urgent action. And I think that the perfect screening tool is never going to exist. We're never going to have all the data that we want to have. Our institutions and systems, we can only improve them. We can't make them perfect, right? So I think for all of us, the question, whether you want to screen or whether you're not going to screen, is, in the context of what you do, how can you intervene to identify, prevent, respond to childhood adversity, to ACEs and other forms of trauma and adversity. And I think the second is largely in this conversation today, which was super interesting. We think about ACE screening in relative isolation to other systemic and structural changes. And like in California, ACE screening exists in this ecosystem of a changing Medi-Cal delivery system, of CalAIM, of the Children's Youth Behavioral Health Initiative, significant investments in workforce expansion and supporting youth and families, right? And I think that in that context, it can contribute to a lot of positive outcomes. And so I think thinking about your system and your structure and the context of that. And so again, like as a youth legal system advocate, I think that the learning about the impact of adversity and trauma is infusing itself more across these systems and really prompting a lot of change. And so I think thinking about how screening fits into that, can contribute to that, can accelerate that to better support children and families is really important. And I think that if we all wait for the screening tool, the screening process, for our organization to be perfectly prepared to do this work, then it will never get done, right? So I think it's incumbent on each of us to think about what role we can play in, advancing things forward to better support children, youth, and families.
Well, thank you all three of you. This has been a really great discussion. I'm grateful to have been here with you, and thank you for all the amazing work that you're doing. You can see in the chat, lots of thanks to you. Thanks to everyone for staying on till the very end and even over. We really appreciate you being part of the conversation today. The recording of the session will be posted to the website. We'll send out some key takeaways. The resources that were talked about will be in the Pathways Resources Library. We also hope you'll join for our next session on October 17th, where we'll talk about supporting Indigenous resilience and knowledge through culture-based programs and policies. It's going to be a great session, so make sure you register at our website. But thank you again, everybody, and I hope you have a great rest of your day. Take care.